De la ce am dorit să pornesc această prezentare? Am luat în calcul mai multe sugestii care mi-au venit inițial. Când am gândit această masă rotundă, am pornit de la niște probleme pe care le-am observat eu în ultimul timp. Îmi pare foarte bine că stă și domnul doctor Tănase. Eu am plecat de la faptul că noi nu avem listă de medicamente compensate.
Started from the fact that we do not have compensated medicine for several years, or at least triple therapy or something. But when we started, these were the only possibilities available, and starting from the situation with hepatitis B, where people are paying from their medicine. On the other hand, we took into account a strategic plan drawn by us and suggested last year together with APAH, launched with the occasion of the Romanian Society Congress for Hepatology. And we are going by this strategic plan, which has to continue. This has to be an endeavor that has to continue, and doctors should join us. But subsequently, we have also added data from the National Health Insurance House that provided us with figures. Starting from this data, on the other hand, with this data available, we realized that all the endeavors of the past years were just drops of water. We haven't seen anything concrete. Many times, at many meetings with the authorities, we're wasting time. And Mr. Lawyer Cimpoieru is here with us, and he can confirm. We've attended several meetings and public debates. We've met the ministry or the national agency on our own expense or on the expense of the sponsors. And we continue fighting. Patients are asking, what have you been doing? Didn't you do this or that? And we say, yes, we do so. And then why can't we see the results? And then the idea was maybe together, talking together, you might draw the attention on what we have done right and what we have done wrong. And I shall start with the data of the strategic plan and the suggestions that we had so far. Just a second. So first of all, we are a country with very many patients suffering of hepatitis B and C. We have two studies for hepatitis C, an official study acknowledged at the European level and coordinated by Professor Liana Gheorghe, talking about 323. A study as official as the other, but not acknowledged at an international level, that belongs to Professor Voiculescu, who says that the percentage of hepatitis C is 55%, and this is confirmed with the recordings of the Center Matei Balș. I understand that the percentage is over 5% in this register also. Yes, around 5%. The latest data is showing this result. This is a statistic calculation. So there are not recorded patients also, but around 5% is what we have. And to this, the percentage acknowledged by ACDC in 2010 is added of 5.6%. So the conclusion is that more than 10% of people in Romania have a viral type of hepatitis, either B or C. And as you were saying, we have to see if they are diagnosed. No, this is just the percentage. We're not talking about those that have been diagnosed, but we're talking according our intuition what is the data. So this is the epidemiologic data. Let's not forget the access to the treatment in Romania. As I was saying, we have a standard therapy, the double therapy for hepatitis C, and for hepatitis B we have interferon and analogous products. And that is what we have available. On the other hand, just as any other Western country, we tend to have more and more patients, if possible, treated with the latest therapies. Talking about that, I have the statistics of 2011-2013. The number of patients with hepatitis C and cirrhosis type C, in 2011 we had 500, 900, 2012 6,200, and 2013 around 6,000. Number of follow-ups with respect to the treatment with chronic hepatitis C and cirrhosis type C, of course, with approximation, 8,400 in 2012 and over 9,000 in 2013. With respect to hepatitis B, initiations in 2011 around 2,500, 2012 2,586, and 2013 over 3,000. Follow-up over 200 in 2011, over 5,900 in 2012, and over 8,400 in 2013. But here I believe we have to take into account the fact that have a long-term treatment. So the entecavir, which is the only option at this time being. Yes, but there is a problem, doctor, that we have discussed yesterday, and the case that has been presented yesterday by Dr. Cipoian of a complex patient with hepatitis B plus C plus D. There's a long story, there's no point in repeating that, but Dr. Cipoian was saying that at a certain point, that patient was supposed to undergo a treatment with the two molecules, and he had to buy one of them because it was not compensated. So for these people, it's a little weird because it's not fair they have to buy this. And several doctors say that there are patients that have to be prescribed this molecule and they have to buy it. We also had patients trying to talk to us and they asked us where do they find this drug cheaper. And I'm talking about disparate situations. The protocol is quite rigid, but we have to see what do we do, how do we handle such exceptional cases. The problem is that we always have exceptions. Fortunately, the exceptions are very few. That's why they are exceptions. And there we have to analyze case by case, and a decision has to be taken, and financial resources have to be identified in order to bring a solution to the problem. That's not up to me. You have to talk about this with the insurance agency and the commissions, the specialized commissions. And I believe that things can be solved after clarifying discussions. I repeat, there are very few cases, and each one of them has to be carefully analyzed, but I don't believe that we have to panic. We have to be alarmed, but not panic. So let's take them one by one. That's the way I see things, because otherwise, if we were to decide for a rule right now, exceptions keep occurring, and they shall start one by one turning into rules, which is not what we wish for. I was thinking that as you have presented, we're just analyzing the pessimistic side of things. Steps have been taken in the past years that allow us to be optimistic because the lists of waiting related to our available treatment are no longer existent. Yes, they are existent in some of the counties where things are going really well. But globally, yes, globally, we're moving towards the right direction. For the existing treatments, there is the possibility for the patients. That's a good thing. For hepatitis B, things go well with analogous products. And lately, there has been another change. The assessment for the patients with chronic therapy is performed after 1 year, which is good. So we have to see also the optimistic side. Another example from the history, 7 years ago, or maybe more, a young boy with B and D was at that time in the protocol published according to the law with a therapeutical treatment that would stop at some point. And then at the concrete evaluation, 21 years old, transaminase 250, stop treatment according to the protocol. And at that point, 10 years ago, I said, no stop. And I continued writing compensated prescription with that treatment. Nobody refused my prescription, and moreover, after a while, the treatment has been officially prolonged for 2 years more. So, in the end, such exceptions, first of all, have to be dealt with a bit of courage from our side. But there are exceptions, as Dr. Tănase was saying, and definitely the Commission, as I know it at this point, is working in the following way. If a physician has medical arguments to support their case, Commission may have proposal. And you also can access the funds of the Ministry of Health and other funds also. But I am convinced that the Commission can intervene this way. I agree also with the fact that indeed things improved in the past years compared to 2009. If we think about the waiting lists, we're way better. Indeed, several modifications have been brought to the therapeutic protocol in the benefit of the patients. Not later, from the beginning of this year, we were worried about the patients that reached the end of their therapy, but the luck was that the protocol has been modified in due time, because we were thinking of the situation in which people were supposed to buy their own treatment. We have to appreciate that. But the problem is the following. We're starting from these situations, and we have to see what can we do and how can we have a collaboration between physicians and patients so that our endeavors towards the authorities change their look. We have to find more concrete situations, because there are some wishes that we have for several years. One, the diagnosis. We have been talking this morning also about this topic. We have been trying as an association of the patients together with the pharma companies to provide diagnosis among population and inside the penitentiaries. On the other hand, doctors have several diagnosis activities. I think Matei Balș is an example with the European funds. It is true, under the umbrella of the Ministry of Health, but the project has been carried out in Matei Balș. Diagnosis for the convicts. We have done this year together with the pharma companies, but I don't think it's normal that things go this way. These actions should be under the umbrella of the Ministry of Health, and the Ministry of Health itself should bring a contribution, and we should go step by step. This would be one aspect. The second aspect, we have to see how can we do so that the information activity about the transmission of hepatic viruses is correlated between NGOs and associations of patients through actions in the schools. In Brașov, we only have one. But they don't manage to cover everything. They come to us and they say, take this material and spread it because it's too much for us. For the treatment, because of course there is a big confusion among the population, I'm referring to the patients, with respect to when can they start a new treatment, provided that they had one treatment, two treatments, or even three. And I would like to reach conclusions together with you, or find ideas better with respect to the ones that we had previously, to send to the Ministry of Health. So present your point of view. Dr. Marinescu, raise the hand first. If you allow me, we have an exceptional case in the room, a young person of 23 years old with the virus B+D. So you should post this case on the website. And considering that we have specialized physicians in the room, maybe he can get a solution in order to improve his hope for life. And this all should be posted on the website about what were the chances, what was the case, and so on. First of all, this is not an exceptional case. He's very young. Yes, he's very young, but he's not an exception. B+D is not really an exception. Of course, is more rare with respect to the other countries, but it's not an exception. Well, it doesn't matter the age. The disease that does not take into account the age or other criteria, it can install in one patient or another. I believe that good things have been done, and I will repeat what the doctor said, and as an association, I have seen you very active. You provided help to the physicians also, and a series of actions have been carried out where maybe things could be improved. You had a series of diagnosis campaigns for viral infections among the population, but on the other hand, also the population should be aware of the fact that once diagnosed with a certain infection, it's pointless to go to each diagnosis campaign to be reconfirmed the same thing, consuming thus funds that could be used to diagnose other patients. It is very good, because I said 2 years ago, with respect to the infection with virus B or C, that in chronic hepatitis with virus B, when the patient has the indication for an antiviral treatment, they have to be administered the treatment immediately, not in some years, because meanwhile their transaminases could come back to normal values according to the normal evolution, and then maybe he or she wouldn't have anymore the indication for antiviral therapy. So it's good that we shorten this period of waiting. In exchange for virus C, I can wait for 6 months and 1 year because things do not change dramatically meanwhile. So things are moving towards the better. I believe that it would be good to have all sorts of advertising materials understandable by the patient and at hand of the patient. And here you can take as partners the pharma companies, because we also authorize them for such advertising materials. And sometimes they want to write down more than necessary, and we don't agree with that. But anyway, advertising materials are very good in order to know the disease, to know what measures to take in order to avoid the disease. These are the most important measures in terms of the association. Steps are to be taken in prevention. This disease should be known. The patient should know what should they do in order to avoid infection and what should they do when infected. And on the other hand, the patient should be aware of the fact that when he was diagnosed with an infection, and I here refer to the virus B, that is forever, they should find a physician that they should see periodically, because I also have patients that come, get diagnosed, get assessed. I tell them to come back and they forget to come back after 6 months or 1 year because they feel well. So they have to be systematically assessed. I believe these are the essential elements to start from, and then the therapy, the protocols, and all the rest. But I believe it's obvious for everybody that in the past 10 years, things moved towards the right direction, maybe not with the right speed. Charles, if you have anything to comment on anything, just intervene. So we would have 3 directions on what could be done. How the information is disseminated to the patient. And here things are not simple all the time, because the means to send out the information, of course, the physician is one of the means. But mass media is very useful. As the doctor was saying, we shall have a testing campaign for hepatitis C or B, and those who already have hepatitis shall go to run this test. Maybe if people are informed better, they don't come twice or 3 times to get tested. Second of all, whenever we address to the authorities, of course, we have to have examples. And small projects that we have been carrying out with the penitentiaries and so on, everything what Marinela was mentioning, are very important because they have conclusions, they are documented, and they can be a signal of alarm, because otherwise, when you submit a request to an authority, you have to bring an explanation, a documented explanation, and the role of the institution is important. For instance, Matei Balș, things have also changed inside the institution. And indeed, the approach of a patient with hepatitis is different. And if this happened at the level of each hospital, institution, and so on, this shall change a lot of problems. In the end, the patient, when assessed, must be provided with a solution also. As the doctor was saying, even though there are exceptions, we have to fight for each patient to find a solution. And we shall solve something. We cannot tell them there's no solution, we just wait. We have to try. Also, in the case of the triple therapy, the agency has provided an answer and said you cannot do triple therapy because it's not approved. But the fact that many files have been submitted in Romania in this respect, it's a signal that this treatment is needed. So actually, our steps are helping us in moving forward. I would like to add up to what has been said so far. With respect to these patients that have triple therapy files, they ask us, what is there to be done? How long do we have to wait? And I'm talking about patients that do not have the time to wait. And what are we going to do? Do we wait in vain? Because we don't know if this is going to be approved. And for these patients especially, I believe that maybe it's good to start again another therapy, or in case of relapse, or what do? They wait until new molecules are approved. We don't know what the future looks like. For the area of Moldavia, Iași especially, where I come from, there are several patients coming to us from Republic of Moldavia that are infected with such viruses, and they do anything possible. Some of them manage to buy the medicine. Those that do not have possibilities try to find an access somehow to these files at the Agency of Insurances. And not only in Iași, also in Matei Balș, there are patients in treatment with a good response, some other with a negative response. But many of the cases that we have are infected from a certain area. And at the present moment, we have started a transborder project to diagnose these patients from Republic of Moldavia. And I think it's good that your association joins also these patients from the Republic of Moldavia that are very desperate and do not have the means to get diagnosed. And we shall see if it's going to be possible to do something.
Ok, ca să facem, înainte de a da microfonul mai departe, înțeleg așa până acum în ceea ce s-a discutat, înțeleg că în ceea ce privește campaniile de depistare, în primul rând, pacientul trebuie să fie conștientizat în momentul în care a fost depistat să nu mai meargă să participe la N campanii de depistare, ci să intre în sistem pentru a se câștiga timp. 2. Materialele informative, nu promoționale. Promoțional e atunci când promovezi ceva. Aici e vorba de informație. Corect?
Sunt de acord absolut deloc cu ceea ce se întâmplă la televizor. Adică cu acele reclame. Și pot să numesc că nu e...
I'm sorry, I cannot hear without the microphone.
Nu sunt de acord cu reclamele.
I don't agree with advertising for certain pharmacies such as Catena, Dona. Personally, I feel ashamed for those who appear in those advertising. I don't agree with encouraging the drug consumption, because we're talking about patients with certain diseases, not people that have to buy hamburgers or other products from Carrefour. That's very clearly. So we're not talking about advertising materials in this direction. Therefore, at the level of the agency, advertising material is extremely well selected, and we're sorry because we don't have the possibility, the legal possibility, to have an attitude against the publicity, both with respect to pharmacy chains and food additives that don't have a scientific ground. Another conclusion of what you have been saying, and what Dr. Marinescu said is correct, whenever we are organizing such campaigns to send information to the patients, it's better to be more careful with the messages and the way we are disseminating such messages. And then the correct preparation of the documentation that is submitted to the Ministry of Health. Many times, whenever we present statistic data and figures, of course we have to collaborate better with you to help us bring our statistics up to date, because lately each hospital has internal studies, and we should collect somehow such data. And then we're working on the arguments, but we have to take into account what Mrs. Moțoc was saying previously, the fact that in the associations of patients there should be a team of physicians to work with. This could be very helpful to us. I would like to suggest something. I believe that the association of patients is not very careful at the problem of the teenagers and children that take drugs and they have hepatitis B, C, D, HIV. Sometimes they cannot benefit of the treatments because they don't have a job, they don't have an insurance. Parents are desperate, and they are very vulnerable from a psychological point of view. They're not mature yet. They desperately need the associations of patients. I believe that we should intervene here also, because we're also talking about our future, and this phenomena is more and more frequent. Starting 18 years old, they are not insured, but they start at 15 years old, and by the age of 17, they have B, C, D, and HIV. This is a very extremely serious phenomena in Romania that we have to be aware of. So your suggestion is that we should have targeted campaigns towards this segment.
Ok. Știu că ne-a fost, apropo de această problemă, ne-a fost semnalat de doamna doctor, aici vă semnalez și dumneavoastră, aduc tot timpul situația din zona Moldovei.
All the time, I am bringing as an example the situation in Moldavia, because there's a very well-prepared pediatrician that draws our attention on children that did not repeat the vaccination and are infected with the virus of hepatitis B at the age of 14 or 15. Did the other doctors notice that? Because we were drawn the attention expressly on that matter. Dr. Moțoc. Vaccination against hepatitis B is less known, so to say, by everybody, including the practitioners in general, and even less by the patients. Vaccination produces antibodies anti-HB at 95% of the vaccinated persons that actually protect from the infection. 5% do not get antibodies. In Romania, this free-of-charge vaccination and mandatory starts from birth, when the immunity system is not mature, and then the production of antibodies is not enough. I have read a few years ago an American study according to which pre-teenager population, considering that sexual transmission is a risk factor and those kids were in the future going to have sexual intercourse, they wanted to see how protected are they. And most of them did not have antibodies anti-HBs. And there was a repetition, but this could activate self-immunity diseases. Out of my personal experience, so to say, testing the children that have HBs antigen mothers, after 4 or 5 years old, those children did no longer have antibodies anti-HBs. So in theory, they are not protected. Revaccination can be done also, even though immunologists are saying that there's an immunologic memory, and in the situation in which you encounter, in our case, virus B, the body remembers and produces anti-HBs antibodies. We see that often in sexual partners that we systematically test for those who are infected with virus B. If we test for antibodies anti-HBs, which is correct, we shall notice that they have very, very high quantities, hundreds of over 1,000 units of antibodies of this kind. Why? Because their immunologic memory is permanently stimulated by the contact with the partner. Any other questions? My name is Sandu Sânziana, and I am a medical assistant. I work in a pediatric hospital with chronic patients in dialysis, but I was a patient. I had a virus C hepatitis, and fortunately, I managed to overcome the moment, but nevertheless, I am involved. And together with the doctor, we have many actions, out of which I am more involved in bringing information to high schools with the help of our sponsors that provided us with informational material that I had to adapt sometimes, because sometimes we have a low degree of education. It's no problem if you go to an elite high school, but when you go in a peripheral high school where they learn how to read or write later on, it's difficult to provide them with a material from which they don't understand anything. So I would kindly ask our partner to contact us, because we are in a team. The physician is very busy, but I consider that we have an important role as medical assistants, and we can do very much. But the communication has to be adapted depending on who you are talking with, a child, an adult, and you have to adapt to their possibility of understanding so that you get the desired outcome. Dr. Marinescu, and then Dr. Grumaz. First, Dr. Grumaz. Talking about commercial, I agree with the doctor. Besides this aggressive commercials for pharmacies, in my opinion, more dangerous are the presentations of a series of obscure products. Unfortunately, the legislation does not allow you to solve such problems or half solve the problems. A green line, for instance. There is that should centralize all the information. So inform your members not to take a decision with respect to a treatment or a procedure without asking that person. That is my opinion, and it's important. Second of all, it's pointless to have campaigns if you don't have a maintaining activity for such information. Otherwise, it's like a wave. It's good to maintain. As an advice, in my opinion, if you want to initiate a discussion, I would start at the level of a county, where you should have representatives of the physicians. A second partner should come from the insurance agency, and one from the Directorate for Health. And the fourth, it's you, the Association of the Patients. You have a discussion, you reach a conclusion, and then you move forward. In the next step, you have to address the local authorities, city halls, and so on, because they are also interested in your conclusions after this meeting. After disaggregating the epidemiologic system after the revolution, the real control of chronic diseases disappeared. It's a level of various institutions and so on. At the level of the cities, there should be just one point. For each chronic disease, including hepatic diseases, there was medical practice that would handle those situations. So one family physician or two family physicians would be necessary, but there has to be a person that should collect this data. This is not impossible to achieve. You have to contact the hospital or the infectious department. You can have there a specialized unit, or contact the family doctor. But I tell you, you should talk, because the health directorate cannot oblige them. This is very important, because you are ensuring maintaining communication on this line. Many times we're talking about insured persons. For those that are not insured, we should intervene from from the part of the Directorate for Public Health, and we have to look in the area for the structures such as deputies that are part of the medical commissions. And you should constantly contact them under initiative groups, and thus you can solve a problem. Because you said, what are the doctors saying? Doctors can talk from a therapeutical point of view, but we cannot provide you with social instruments. But Public Health Directorate and the other authorities and the representatives of the government in the area needs to have as few problems as possible. And you can be told what are the limits and what's possible to be done in this respect. And the association of the GPs is very important also with respect to children, the drug addicts. There's a series of associations that are fighting on this direction. And you can collaborate, but you have to have systematic meetings. So we have the Association of the GPs, the Association Against Addiction, and you should know that at the level, at the regional level, for instance, in Cluj, at the level of police, fight against drugs, University Babeș-Bolyai and other structures have a fighting convention against these elements. So, as you were saying previously, every time that we have a diagnosis, we should introduce that in a system. That is possible. You can record this in the system. But for those who do not have an insurance, regardless if they are drug consumers or other categories, we only have the recording because it won't be possible that they are evaluated. This is also the case of the HIV infection. There could be a program that does not take into account the status, if they have insurance or not. This does not mean that we encourage them not to have an insurance. And then we have something else. We should introduce and solve this problem, and related to the testing with HBs antibodies. Each time we test for hepatitis B or C, this happens all the time, there's also the part of antibodies HBs. Many times it happens that they are not tested. There's another problem. Whenever we don't test the adults, there's no problem related to costs. And in some of the situations, this is the reason why people do not get vaccinated. And I have seen prices that vary much. We had in the institute at a certain point, there was a lower price if you bought the drug in the hospital and a higher price if you bought it from a pharmacy, even double in some of the cases. Yes, it's the price on the shelf that includes the percentages for all the dealers that intermediate. Of course, the price is way lower. I believe that it would be preferable because there are not very many patients, or not patients, people that are checking the level of antibodies and they're checking the level of the immunity. I believe it's somewhere around 50 lei
Odată la nu știu câți ani, dacă stăm să
Once every I don't know how many years, if we have to calculate how many packs of cigarettes or bottles of alcohol are they buying, if they invest 100 lei in order to ensure the revaccination for hepatitis B, is not the end of the world. Of course, you cannot obtain everything free of charge. I have an example. In 2003, I had a test antigen HBs to everybody that I have met. Out of 80 persons that got tested, just one agreed to take part in a free of charge vaccination program. The rest of them were happy to be explained what it was about, and they bought the vaccination and the revaccination. And this is demonstrated by the database. Besides that, the collaboration with the doctors. It's important to take into account one fact. There's not a physician that is good in everything. There can be a young doctor that wishes to get specialized and offer something in hepatitis, and the learning curve is shorter, and they can be very well prepared in hepatitis, but not university professor. And you should focus on that also, because volunteering in medicine has been a rule. So you have to declare officially that you had no night service paid in the health system until I became primary physician. So we're used with the volunteer work in the medical field. And I'm convinced that the new generation, if it's educated in the same direction, may offer volunteer work on a small segment to be the most prepared in hepatitis, even though at the beginning of the career. We're trying to convince a doctor here to stay on hepatitis. It's here in the room, and he's been in the room last year, and Dr. Moțoc helped us. So if you, as experienced physicians, bring us such residents, we shall encourage them, because we also had a case in Iași of somebody that became a very famous doctor, Dr. Huțănașu. We're trying to encourage Dr. Obretin to stay with hepatitis and do extraordinary things. And your idea seems very good. If we encourage them, they stay with us, especially if they take part in such meetings. But I would like to go to access to investigation. You know very well that a big problem, the access to investigation related to hepatitis. We have the viral marker test. Of course, for certain categories of populations, starting 1st of July, also the GP can send you to get tested for viral markers. Of course, we had several discussions with respect to that. Some family physicians say that I cannot do anything. It's incorrect. They can do something. Or at least they can send the patients to where they can get tested. You, as physicians, already specialized on hepatitis, what do you think about that? What do you think that could be done to somehow increase access to such investigation and diagnose patients in time? Because you see every day cases of persons diagnosed too late. I come back with the observation that in Iași, pharma companies have been involved, APAH RO and MSD, that at a certain point, 2 or 3 years ago, provided a number of tests, so that in our hospital we established a unit where patients could get tested. Moldavia is a poorer area, and there are very many patients that live in the rural area and have these problems. Here, GPs are very important. Some of them have been compliant, some of them not. At the time being, they are more compliant. The problem is that I have seen such vouchers forgotten in the drawers, and the patient was asking, how can I get tested? In this framework contract for viral hepatitis, the patient can go spontaneously to get tested. And the last thing I would like to emphasize related to the screening, first of all, patients do not have an access limit. They can go spontaneously according to the law. It is very important that they are informed in this respect, and the companies that make available the tests. Let's not forget one thing. Hepatitis are ambulatory diseases. The hepatitis in the hospital is something that we don't want to see. They can go spontaneously at the family physician or the specialist. I wanted to clarify that. They can go and say, yes, I would like to get tested.
Bine, în afară de asta.
Aș preciza, da, e foarte important, mi-am dat seama, pentru că sunt undeva deja de mult în domeniu. Deci e foarte important.
It is very important that the specialist brings arguments. So after an ECG, you have to bring arguments, but you have to know that the law allows you to do so if a case is documented. So, of course. I am not talking about hepatitis in the hospital, only starting with cirrhosis. When I authorized the private hospital, the ministry said, why do you need beds for gastroenterology? And I said, there are some cases. And the ministry said, yes, there are some cases, but I don't do the hepatic functions in the hospital. I do that in the ambulatory, or the ablations with radio frequency. I had to carefully read these norms issued in June 2014, and the assistance for chronic viral hepatitis can be of many types. In specialized ambulatory, which means specialized physician from the clinic or the hospital that provides such services in contract with the health agency. Our hospital does not have a specialized ambulatory. We are recovering them in the hospital based on a certificate that sends them to us, because otherwise we cannot reimburse the money through the health agency. And if we're talking about more than 3 days, is the case that we don't desire. On hepatitis B and C, usually we reimburse 220 lei that do not cover the costs of a viremia. And then the patient has to pay for that. There are other diagnoses for those treated with professor introduced the assessment, but the next step after the evaluation, after the screening, the evaluation. And for the GPs, they have the right, together with the other investigations, to give the hepatitis markers.
Deci, ca să fie foarte clar așa. Nu. Sigur.
Of course. So just a second. Here there is a story. First of all, the GP, you know, according to the contract, they can handle 20 patients a day. 28? Yes? The family physician? No, no. I'm talking about the family physician. Each time they provide a prescription, they have to see the patient. And now, the only thing that is not taken seriously is that yearly control that the patients should do. For the specialized ambulatory, you have 28 patients at most, but you cannot receive them unless they have a referral. Yes, they come spontaneously, but you have to justify. And what about the financing? Personal experience starting July, framework contract, private hospital, I risk everything. We're talking about the ambulatory. We're not talking about different things as long as we access the same funds. Hospital, private hospital, contract with the health agency, framework contract, the same for everybody. And you're a private and you to pay 10 times more in case of an audit. Framework contract, clearly written, Annex 13, spontaneous patient, code 34, viral hepatitis. Patient comes there and says, I'm here to get tested for hepatic viruses. The first thing that I have to do is to check if indeed I have medical grounds to get them tested. Lack of contact chance, ECG, evaluation, and so on. But I can do that at a spontaneous patient. After which, the antigen HBs antibodies, and in the same day, I take the blood samples and I send it to the laboratory, and the expenses are reimbursed by the health agency. I don't need a referral for that. Okay, let's clarify, because we have here two opinions. First, you say that it's possible in a certain context, but what do we have to say to the patients? What is the message? The message is that they should have a referral from a GP if they go to a hospital like Matei Balș, Victor Babeș, and so on. Make the difference between the ambulatory and hospital. Let's try to understand the message of the ministry. Why do you need for gastroenterology and hepatology a hospital? So very many for the patients. I'm a primary physician in gastroenterology, are treated in the ambulatory, in specialized ambulatory, which solves, in our topic, for instance, over 80% of the cases. So the conclusion is that if they go to the hospital, they need a referral, but there have to be arguments based on which they are there. An argument can be the one that I come to get tested because my father has hepatitis. Yes, of course. This is very important. I would like to move forward because we only have 30 minutes left, and Charles would like to have an intervention also. I've worked very much in the ambulatory as an internal physician, and I've worked a lot with the health agency. And they check, and then they provide a paper that you have to send back. The problem is that whenever you have performed investigations not approved by them, you have to pay for everything, you as a physician. So be careful. And so is the case of the emergencies. Second of all, if I had 28 patients, of course, the person that requests the service has to schedule. But for the rest, if I'm a patient that risks to be infected with hepatitis, I work intensely, and at the end of the work, out of 10, 2 have a suspicion. Who pays for me for the other 8 patients for which I have worked? But you're not reimbursed only for the diagnosed cases. You're reimbursed for seeing them. Are you sure? Yes, I've been working like this so far, until the Court of Accounts comes to see us each 2 or 3 years, and you have to give back the money. That's very important in the end. I am sorry, I cannot translate if she doesn't use the microphone. She doesn't use the microphone, I'm sorry.
După 2 ani de zile vă cer câteva miliarde înapoi. Nu, de pe spital vă spun eu, vin după 2 ani.
Can I just say a few things? We have the same problem, interestingly, in the UK, well, in England, where our system is changing, and nobody is exactly sure about who is paying for what. And that is clearly something you need to find out, as do we. But I'd just like to step back a moment. What I'm hearing here is how incredibly important it is that physicians and patient groups talk together, because there's clearly bits of information that patient groups need, and maybe doctors need too. And to take a more kind of general view of this, I think that what we did in the UK was to set up an advisory group of clinicians that we would have regular meetings with. And we could discuss some of these things, but also priorities for action. Because there are two major areas, in my experience, where clinicians and patient groups can work very well together. The first one is around information. And one of the things is that generally clinicians, and that includes GPs, do not have the time to give to patients that patients often need. And so if there's a patient group that can do that, that's fantastic. But you have to be sure that the patient group is giving out the right information, which means you have to meet the patient group and give them that right information. But also it's about making sure that clinicians know of the existence of that patient group. And very often we have been at this in the UK for 12 years, and there are still hospitals who do not give out our information when they see a patient for the first time. And considering how much we can help them by providing information and support and things that the hospitals don't have time to do, that just seems mad. But anyway, that's something that you can discuss. And then clearly the other thing is around advocacy, and how important it is that if you are going to go to government bodies, that clinicians and patient groups go together and speak with the same voice. And the patient groups provide the immediate and emotional appeal, and the doctors can provide the supporting evidence that is so crucial to this. And one of the other things that we have not really succeeded with yet in the UK is getting clinicians to ask patients if they ever want to go public with their story. Because clearly the media likes the emotional impact of patients talking. And what we have tried to encourage clinicians to do is to ask patients this and then put them in touch with us as the patient group in the UK. But there are many of these areas where clearly it seems to me very important that you as clinicians get together as a small group and talk to the patient group on a regular basis, not just like here once a year at a conference. Because I think you will find that you can advance the cause of hepatitis much more quickly if you do that.
Foarte bun comentariu și foarte util ceea ce
A very useful comment.
Care este părerea dumneavoastră din sală?
What is your opinion in the room? Anybody has anything to add? I believe it's very important what we just heard, and I believe that's how we should work. I would like to move forward. I understand from the discussions with you that if we correctly inform the patients about the access to be diagnosed, the problem is solved. If we know how to say the patients where to go and when to go, and physicians should go by the framework contract. That is my conclusion after these discussions. And with respect to testing, we shouldn't necessarily work on the part of how we do the test, but how the patient and physician work. They should know that the law allows them to perform certain actions, so that specialized physicians are reached by people that need the treatment and the adequate monitoring. And then the patient pays money only for those tests that are not supported by the state. And we're talking about the viremia that sometimes is supported by the pharma companies, which does not seem very normal to me. I consider that the state should contribute at least with a percentage, because you know very well very many patients do not get tested for viremia because they cannot afford to do so. And then they are not monitored. And if we add to that a fiber test or fiber scan or whatever else, money are added to that, an ACG every 6 months. In conclusion, what do we do? What do you think? What should we do? Should we bring arguments from the associations of patients and go together to the ministry and say if we fail to do that, these people die because they will get cirrhosis? So what are your suggestions? Because we have to see, we have this issue. And then we have another issue. After monitoring, what do we do with the patients that are not compliant to the treatment? I know that this is the case very often in long-term therapy. There are patients that, for instance, produce the treatment by themselves with no indication of the physician. So, suggestions?
It was also discussed if we were to think punctually, when we have a diagnosis, we know if the patient has a hepatitis B and C, he's monitored by a specialist doctor, and from that point, the monitoring should be continuous. Because I don't think there exists a doctor who says you no longer need to come to me. So related to the compliance part, no matter how we will try, there are patients with lower compliance. But the relation established between the patient and doctor is very important. For example, to interferon, how many times does it happen when the patient does not make a hemogram, and after a certain number of months he doesn't feel well? If things are explained from the beginning that he should make a hemogram weekly, I think things will look in another way. And also the adverse reactions to interferon could be prevented. This is not a rule, of course. It can happen at a certain point. And you can see this from the examples given by the patients if you ask them. When a patient already diagnosed with viral hepatitis B, C, D, we make a plan of investigation together, and if we reach the conclusion that he needs a treatment, the first injection, puncture, is done in our hospital, in our presence, so that we can explain him what to expect, and more than that, I give a letter of monitorization, a written letter, which says that the hemogram must be carried out at a certain interval of time, and any other investigations and analysis that need to be carried out. Because the person may forget. And even patients who are not treated, for those with viral hepatitis B, I made a small plan of monitorization in which I say that the lifestyle needs to be healthy. That, for example, you must have an ultrasound, and the best method is this, for example. And if you don't receive treatment for now, you can receive it another time. And each new patient that comes in front of me, for example, I give them once or twice a year, I give them written these recommendations as attachment to that official letter. Maybe if these measures would be more known, of course we can write these measures together, and these plans can be conceived together. I think then the patient will be more informed. There is this part, the patient has to read what I write and respect this, because I don't know how we will punish them otherwise. I think faith punishes them. Also, from our daily practice, the patient is identified with a virus B or C. For example, for virus B, the problem number one,
antigenul HBE, anticorpii anti-HBE, specificați la deocamdată nu sunt decontați de către casă. În această privință, asta este primul, și anticorpii anti-HVD. Deci asta este prima problemă cu care ne lovim. Deci de la situația, în istoria mea, 10 ani de hepatite, totul în ambulator,
in my practice,
peste 600-700
practically over 600 patients. I think there are 10 or 15 patients who cannot do these investigations for free. They didn't find a solution. And then we raised money. So every person, for example, paid 5 lei and paid those investigations. It's extremely simple. So moving on, the patient is identified, screened from this point of view. The hepatic puncture must be carried out. Another clear point, the hepatic puncture is not reimbursed by the agency. The histopathological exam can only be carried out if he is hospitalized. I refer to the free of charge. So, again, we have two possibilities here. Either you make the puncture in hospital, just to make the histopathological exam for free, or you can collaborate in a certain way. For example, in my hospital, from my section, when we left, nobody else carried out the hepatic punctures. So I said I will make them for free. For every concrete problem there is a solution. The patient cannot have this hepatic puncture. There are many situations in which the fibro test is under-evaluated. The patient is eligible in reality, but the fibro test is not so accurate. We must think also to this option if the fibro test is not relevant. There is also the possibility to address to the studies and projects on European funds, because many centers have projects, and also then the fibroscan can be made on projects. There are companies who reimburse totally or partially the fibro tests, but this should always be specified clearly.
alegi. Pacientul este
The patient is finally eligible and he is the file is submitted to the insurance agency, and the therapy is approved and he begins the therapy. There is a law that we all comply. He comes to write the first prescription. Of course, you make the basic evaluation, hemogram, ultrasound, any other investigation.
Noi știm fiecare la ce moment i-am depus dosarul, dar eu uneori mai mult sau mai puțin de când l-am depus. Trebuie să știm acum cu cine discutăm.
We started the treatment. At any type of viral infection, there are certain rules. Monitoring on 3 months, because you have to make an extension file. And you must specify certain things. All of these, after the initiation of the treatment, are reimbursed by the insurance agency in the specialized ambulatory. But when you write the prescription every month, nobody stops you to consult the patient and send the analysis to the laboratory. And for example, the second consultation is not paid by the insurance agency. These are things that we make on a voluntary basis. Also, the monitoring within the legislation are all in this context. This is correct, but these viruses are according to certain agreements with pharma companies. I know there are on the sites at least the agreements that lead to therapy, but we are strictly speaking about patients that have to follow a certain therapy and that have to monitor for all their life. This happens with a lot of persons. I try to emphasize what can be solved and what are the solutions. These are problems that no longer do not have a solution yet. Then, for example, patients finished therapy with double therapy, and they need to be monitored. For example, a patient asked me if she can make an ultrasound before having a child, for example. Concerning monitoring, let's be careful to transaminase and antigen in a quantitative point of view, because as we all know, the transaminases are no longer monitoring criteria. So we are starting from these problems. What can we do? I make some suggestions. We suggested the authorities to have one free investigation per year. What do you think? How we can do this? Because we need also your opinion, your doctor opinion. I'm referring to the professional main associations in this field, the Association of Infectious Diseases, which I think needs to support us with studies. Say, for example, if the patient did not pay something, I lose this patient because he doesn't have the necessary money to perform certain investigations. This is the same for hepatitis C. There are many situations in which for B, you cannot make treatments from the beginning. There are more patients with hepatitis B and who are monitored for a longer time. This would be ideally to find a solution for this. At a certain point, this is also a discussion. We would reach the situation in which we will have the virome should be performed in a certain point. It's clearly obvious that some of the patients cannot do them, but they will be compelled to. Things have changed with respect to the pharma companies. Now I look at you. He's looking at me because I represent one of the companies that support Veramis. These things can also change because they are supported through a protocol. But at any time, this agreement can no longer exist. And we need to have a solution for this Veramis. We can also discuss, referring to the price of the Veramis, which is higher, too higher in our country. Maybe we can reach a negotiation. Let's also refer to norms again. That evaluation code of the virological reaction should be the response of the body. We can work at a Verami because the reimbursement covers the cost of only one Verami. The insurance agency, if for day hospitalization, so the contract of the hospital with the insurance agency for daily hospitalization, so each hospital makes the contracts as it considers adequate. And if this reimbursement is carried out, in my opinion, we can also make a Verami without abusing this. For hepatitis C, things are simpler because you only make one Verami when you took the person into evidence. If it is eligible for treatment, he enters into treatment, and then you can see how he responds to that treatment. And after 2 or 3 years, you can actually confirm if the disease is cured or not. So that person no longer needs to perform a Verami even though the antibodies are positive. If he does not enter into treatment, there's no way in performing that Verami every year. So you need to make it only in relation to the antiviral therapy, how he responds to it, and if it is cured or not. For B, things are, as the doctor said, you do not treat it from the beginning, and you must know when to intervene with therapy. In that moment, the medical guides say that the treatment indications come from the Verami that exceeds a certain level and the hepatic diseases. For example, certain countries use only the fibroscan, and if it exceeds 7 kilopascals, the patient enters into treatment, but in Romania, they accept only puncture, fibromax. We must agree what are the treatment indications. Maybe, I don't know if we can make a Verami once a year, but when you consider this is necessary, you do no longer need to perform this Veramis and be stressed. The cirrhosis does not come overnight, for example, does not occur overnight. So, we do not have to exaggerate. The people handling those Veramis must carry out according to a plan of specialists and also updated every year. The Verami for D is very expensive, is not reimbursed by anyone. So this is a problem, considering the fact that if you enter the site of hepatitisdelta.org, Romania is in red, as any other countries, with the prevalence for hepatitis D. I saw many patients who came with cirrhosis and who were told that you have low B viremia, but actually he had a D1. We only have 10 minutes because we also need to go to lunch. I make a suggestion. First of all, it's clear that this discussion, in order to have clear resolutions, we have to continue it on mail, and I kindly ask all doctors who participated to give your consent to continue this discussion on email. I will send you these conclusions, and I think it's clear to make a request to the professional associations, companies, so that we can have a common document, and also an undertaking to the authorities to have this analysis compensated, and how can we bring arguments together, because we need to work together. And it's clear that, as the doctor said, we need to have clear norms depending on the cases. If we are talking about a patient with hepatitis B or C, or a patient which had very good analysis for years, this should be all indicated clearly in the norms, but in the same time we need to think to the moment in which the pharma companies will say, stop, there is no free viremia, now you have to handle on your own. And concerning the informing campaigns, we need to make them with the supervision of a doctor. This is the conclusion that I reached after this discussion, and they must be very good argumented. I come back to a question: how do you think that us, the Association of Patients, could intervene to increase the compliance to treatment? There are persons that forget to take their pills. How can we do this so that the ANM does not accuse us that we are advertising a certain medicine? So for the treatment of syphilis, there were certain clear rules. I think we need to inspire from there. If the patient first doses were taken in the presence of the nurse, there were certain rigorous norms to administer these medicines so as not to spread the tuberculosis or syphilis. I think we need to inspire from those norms. I know that they existed. I would suggest, first of all, to ask the patients, because for the persons that do not take the pills, the exceptions only confirm the rule. But if the patient does not take its pill, it's a frequent situation, of course we need to take some measures. I must be practical, because in the patients treated by me, I'm sorry I do not have any figures, in the moment in which they come monthly to take their prescriptions, I do not ask them personally, but within the organization way, there is a nurse that only deals with this. And it's important because the nurse deals with this because he very likes the subject. So the fact that every month he writes the prescriptions, I only check them, and she meets with the patient and discusses and asks about the patient's health situation.
care muncesc în țări străine și care vin
For example, young people who are working abroad and can come with vast experience know that there are nurses who are specialized in certain fields and who are very dedicated to what they are doing. They do more than, for example, than the doctors who need to take care of more than one thing. So we are reaching the conclusion that we need certain specialized nurses for hepatitis. If you don't pay them, they do not do voluntary work. They do as far as they can. If we are in the private field, I must recognize that the last discussion at the level of the salary was 3 days ago with that nurse, and I said that I think you do more than I ask, and I think I should offer you a bonus, and I had an idea. So you pay me exactly as I consider you should pay me at the moment. So this depends on the person. I think this is a measure that should be taken together. Is it necessary to have these specialized nurses or not? I think it is. I have this distinction here. Private sector is one thing and the public sector is another. I'm convinced anyway that when you realize that that patient has a long-term exposure, the human implication exists, and I think our colleagues involve emotionally. When you have 30 or 40 patients, so per day, if we divide it mathematically, the nurse does not have time to speak with each patient and ask him if he took his pill or not. Half of the time spent by the doctor with that patient is bureaucracy. He must take care not to mistaken the code, because after a while he comes and imputes this as a doctor, imputes this on you. But I didn't understand what can be done from the perspective of a patient, because we have two separate opinions here. I think you should defend us in the future also. People, when they will have to pay for certain different interpretations of the famous norms of ministries, things will change, or not as they seem. The paradox is the following. As long as the associations of patients do their job best, they make marketing, the state does not interfere. In the discussions with the foreigners, there were certain arguments with authorities who claimed that why did you have to press charges on us, for example. Maybe it wasn't me who had to ask about this, maybe the patients should have asked to see what happens with the compensated medicine. And we've talked about the commercials, and the discussions, first of all, are a mixture. I believe that what suggested President Borcea is very common sense and very coherent. First of all, we have to do something concrete. We have been talking about a protocol. I'm talking from outside, and I'm trying to draw a neutral conclusion. because I'm neither patient nor... Yes, but you are very involved in the Patients Association. Yes, the problem is the following. We're talking about spontaneity. Spontaneously, we're talking about the person that can go or not. There are pros and cons related to that, because Romanian bureaucratic system is precisely this. After a while, an employee checks and decides to charge against that physician. And the answer will be, it's not written this in the protocol. And now concretely, if this is a problem with spontaneity, let's modify the protocol. And how do you do that? You open the computer and you draw up a concrete proposal. We suggest to modify the following, something concrete. And such concrete suggestions, for instance, if you go to ministry and say we want free of charge viremia, nothing happens. But crystallizing and identifying the problem with the necessary means, and that is a protocol, that you have to bring something concrete, a text, and show how would you like it to be, and support it with arguments. Exactly. I wanted to open a discussion. Yes, but discussions are deeper than they might appear. Yes, but time is off. 2 minutes. Physicians and patients care about each other, and that's how it should be. And again, concretely, even though the trial I was talking about has been won, physicians refuse to continue prescribing that medicine. Why is that? Because they were afraid. They said, maybe we keep out of that, because right afterwards we had controls, and this is a reality. The first reaction of the president of the Medicine National Agency, do you know what it was? We shall control those doctors to see how did they prescribe that medicine. And it's a paradox. Why don't those who represent the profession do something? The College of Physicians, it's like the lawyers. If they sign a legal opinion, nobody can say the contrary. Here is an aberration. So the physician prescribes a medicine, they sign and seal, and a state secretary or whatever, who's not a physician, even though they graduated medical school, says it's not okay. We'll check and see what those doctors did. It's not okay that a physician is judged by a clerk on professional matters. And that is something fundamental, because the representative of the insurance agency is a clerk. He doesn't know what viremia is, spontaneous patient, and so on. Thank you. Unfortunately, we have to end here. I thank all the doctors that agreed to take part in this meeting. I hope it was useful for everybody. And 2, there shall be emails, after which we shall draw the conclusions before the press release. I prefer to wait more and to have all the data. So Camelia quantifies all this. And my request is, help me reach these conclusions. 3:10, is it okay to come back? Okay, thank you.